Hello everyone, this is Randy Clough from MCOL, and I would like to welcome you to our webinar event today, Capital BlueCross, Accountable Care Arrangements, a Regional Plans ACO Approach. Our speakers today are Jennifer Chambers, MD, Senior Vice President and CMO at Capital BlueCross, and Denise Harr, MD, Senior Medical Director, also with Capital BlueCross. Before we begin, we have a few housekeeping items to cover. If for any reason you experience technical difficulties with the web portion of today's presentation, please print off the PDF version of the presentation that was included with your dial-in instructions. The link is healthwebsummit.com/capital ACO 052715.pdf. Our speakers will be taking questions today using a live chat feature. So now at any time throughout today's webinar, you are welcome to submit your questions. As always, if you require any other assistance, please contact the Healthcare Web Summit office at 209-577-4888. We are now ready for our speakers to begin.
Thank you so much for your kind introduction, Randy. This is Jennifer Chambers, and as you mentioned, I'm Chief Medical Officer here at Capital BlueCross, and we're very excited to present today our accountable care arrangements and the work that we have done in value-based programming in our region. So a little bit first about Capital BlueCross. We are a leading health insurer in the central Pennsylvania region, including the Lehigh Valley, on the eastern edge of Pennsylvania. And we have been providing products and services to individuals, families, and employers for over 75 years here. We truly consider ourselves members of this community, helping to support a healthier future for our customers with more choices, greater convenience, and better quality of care. I'll speak a little bit now about our strategy and vision. As the member-focused health and medical value leader, Capital BlueCross seeks to develop initiatives that align the goals and objectives of all key stakeholders in the healthcare delivery system regionally, providers, payers, employers, and members, around a core set of values. And these values are grounded within the triple aim of high-quality care, improved customer service, and lower healthcare costs, or best value for every dollar spent on healthcare. We see ourselves, though, as exceeding triple aim by including provider experience and satisfaction in our value core set, as well as in the measures that we monitor and trend over time. And I'm happy to say that we have been successful in driving our goal to exceeding triple aim. We are meeting provider and member needs by enabling a healthcare delivery marketplace where the key stakeholders have ready access to information and resources that are needed to make informed choices that are grounded in considerations of the triple aim. Next slide, please. So now I'll talk a little bit about our value-based programs. Our accountable care arrangements were first introduced in 2011, and our Quality First program in 2012. All of our value-based programs include patient-centered medical home concepts and principles that undergird success of these programs. In other words, if a practice is not well grounded in the concepts of a patient-centered medical home, they would really struggle to achieve any financial or quality rewards in our value-based programs. Let me speak first about our Quality First Primary Care Recognition Program, which provides enhanced fee schedules to primary care doctors who deliver better care to Capital BlueCross's customers through quality and efficiency measures, and rewards these doctors for best value in delivering high quality, efficient, and patient-centered care to our members. The higher the provider scores in both measures, the greater the financial opportunity the provider has to realize. And the tiered compensation model ensures that each provider is being rewarded for their individual contribution towards improving patient outcomes and controlling healthcare costs. Providers are tiered every 12 months based on these measures and reestablish their new fee schedule based on their outcomes. This model is currently impacting over 130,000 of our members at Capital Blue Cross. Next, I'll speak about our accountable care arrangement models, of which there are 3 noted. Our Quality First Primary Medical Neighborhood, or mini ACAs as we lovingly call them, were created to allow for independent and small group practices that are not part of an integrated delivery system to have an opportunity to participate in value-based programs through Capital Blue Cross. The core principles and program is identical to our accountable care arrangements with one exception, and that is that the financial program limits upside risk compared to the other 2 models. These practices typically are not going to be capable of assuming any downside risk, and we recognize that. However, they continue to bring significant value to the marketplace as independent practices, and we are seeing these launched primarily in our rural areas of Pennsylvania. Our first launched in 2014, and they are located in Adams and York counties, which have significant rural areas in both. Next is our shared risk model, or PHO model, which was really designed to address large group practices and hospital-employed groups who are entering into the population health management space and have not yet gained enough experience to assume significant downside risk. These relationships include upside and downside risk over the course of the agreement, with the express intent to eventually move to a 50-50 split of any upside and downside risk between the payer and the provider. Third is our full risk model, which was designed for those organizations that have demonstrated their ability to effectively manage the total population health of the members assigned or attributed to that provider. The financial model consists of establishing a global budget in which the provider is financially at risk to the target for both upside and downside risk. Currently, Capital Blue Cross has 7 accountable care arrangements through Central Pennsylvania and the Lehigh Valley, with both independent physician groups and integrated delivery systems that serve more than 100,000 Capital Blue Cross members. We are in deep discussions around the full risk model with a provider and are expecting to implement this later in 2015 or 16. Now I'm going to toss the baton to Dr. Harr, who I'm privileged to call my colleague. She is a Senior Medical Director for Medical Value Initiatives here at Capital Blue Cross. And thank you, Dr. Harr.
So thank you, Dr. Chambers. I'm privileged to be here and provide some more of the detail around our accountable care arrangements and really the different components of these arrangements and the different teams within Capital Blue Cross who support these provider relationships. What I'm going to do is first provide a general overview of our accountable care arrangements and then really go through some of the detail around the financial model, the clinical support component, the quality program, and then the data sharing that's an integral piece of the success of these relationships. I first want to talk about and really review just a general overview of these accountable care relationships. And I feel that the first bullet, that these are partnerships with our primary care physicians. And that's really an integral piece of these models, that these are collaborative relationships with a personal touch. And we're working collaboratively and collectively with our partners to drive outcomes. Our focus is on population health management and ensuring that our members, the patients of our provider partners, are receiving the right care in the right place at the right time. We feel very proud of the very highly qualified team that we have assembled at Capital Blue Cross who supports these relationships and I feel are a very well-respected team when it comes to working with our provider partners. The team members are seen as peers to our providers, as the majority of the members have worked in the provider space and understand the challenges that providers face when they're undergoing practice transformation. But we understand how important those practice transformation activities are to the success of value-based relationships such as accountable care arrangements. So by optimizing the use of technology-enabled tools, we can identify customers, patients, our members who have complex medical conditions or those who are at high risk and identify them for appropriate outreach, education, and referral for additional clinical intervention, wellness, or community-based services. And really, again, our focus is on the delivery of that patient-centered holistic care. We build incentives into our programs to encourage our partners to work collaboratively to re-engineer care delivery, share best practices, optimize efficiencies in processes, and utilize all members of the clinical team to the top of their licensure. All of these activities driving outcomes tied to the triple aim and placing the patient in the center of the relationship. I like to use several descriptive terms when I think about accountable care, and we really try to maintain our focus on these descriptive elements that include proactive, patient-centered, accessible, coordinated, comprehensive, and evidence-based care. I'm now going to move on to the financial model of the accountable care arrangement. Our financial model is one that encourages and supports accountability and performance. It's important to note that no financial incentives are awarded in these programs before predefined quality metrics are met or exceeded. And we heard Dr. Chambers obviously reiterate this statement earlier, and it's something that we continue to stress and place a high priority on in these relationships. And it truly ensures, that focus truly ensures that any short-term improvement in cost is not generated artificially at the expense of quality. In general, practice transformation is not without the need for resources which can have a cost associated with them. And as practices and providers are looking to jump into the space of value-based healthcare and looking to adopt the principles and the concepts of patient-centered medical home, we realize that there is an investment of time and energy to put those processes in place. We want our financial model to appropriately incentivize providers to engage in and continue those transformational activities, that transformation of the healthcare delivery system to one that rewards based on the value of care provided as opposed to the historical volume-based model. I'm now going to move on to our clinical support. A key component of practice transformation that is really the impetus to driving successful patient outcomes. You'll frequently hear our team comment about the fact that medicine is a team sport now. And we work with our providers to understand that the patient relationship, while the heart of that relationship is between the patient and his or her provider, we've come to realize in this day and age that medical care requires a team of clinicians, all with their own skill sets and resources, to optimally care for and meet the needs of the individual patient. One of the first things that we do when we are beginning early discussions with a provider partner is to do a needs assessment around what processes, what activities are already in place in the practices that would be providing this additional clinical support. Again, supporting that patient-centered medical home concept. And through that needs assessment, we can determine areas where a provider may be very comfortable taking on those activities, such as proactive outreach to patients in need of services, or working during the very vulnerable transitions of care time when a patient may be discharged from an inpatient facility and going back to their outpatient care team. So we want to ensure that we're meeting all of those care gaps and those needs, but clearly understanding the roles and responsibilities of each party so that we can ensure coordination and alignment of the clinical team that is working alongside of the provider partner, and then the clinical team that we can provide those additional resources from Capital Blue Cross to complement what is already being offered. At no time do we want to confuse the patient by outreaching excessively by too many people from too many different organizations that would potentially just turn them off to the whole healthcare system because they're confused about who they should talk to and what they should be talking to that individual about. So again, this is really an area of focus that we work to very early on, very clearly delineate in our relationship. That being said, throughout the course of these relationships, as practices become more adept at their own internal activities or build up the capabilities of their care team, we realize that this clinical support needs to be an ongoing conversation and one that is often in a state of flux as we work with our provider partners. I'm going to move on now to our quality program. And again, as we've reiterated now several times, the quality program is a very important piece of our accountable care arrangement model. And those quality targets and metrics that are set need to be met before any financial reward is received in these models. So the quality program encompasses a holistic approach to population and individual health management. We use and incorporate nationally recognized HEDIS measures which focus on preventive care, chronic condition management, and acute care utilization. We are proud and have really worked hard to ensure that the measures chosen for our program align with programs and measures that our provider partners may already be familiar with through other programs in which they may be participating, such as MSSP, Meaningful Use, and programs that other payers may have available for our providers to participate in. Again, I think the expertise of our team has allowed us to understand the challenges of a one-off program where the expectation is that providers will adhere to these measures for X payer and another set of measures for the next payer. It's really something that is not feasible, as providers' focus needs to be on the health of their patients irrespective of the program or the payer that may be also supporting that individual member. We also work and incorporate into our quality program patient satisfaction surveys, such as CGCAPs, to support the evaluation of member experience. When it comes to measurement and evaluation of our providers as far as their quality program performance, we use a two-tiered approach. We evaluate each measure using regional or national benchmarks, but then we also look at year-over-year practice performance trends. So we're looking to acknowledge and reward both the attainment of a targeted benchmark, but also the improvement over a prior year's performance. And we want to continue to incentivize our providers to continue to drive those transformation activities and progress toward that ultimate goal. And they need to see that those efforts are being recognized. So providers can receive a portion of their bonus for a given metric by improving their score year over year, but they will receive full credit for that metric when and if they reach the targeted benchmark. This is an area where, again, we've had a number of very collaborative and informative discussions with our provider partners in reaching this scoring methodology, and based on their feedback, have really come to this conclusion as the best way to score program performance in our quality program. And now I'm going to move to the data sharing component of our accountable care arrangement. Data sharing is absolutely the cornerstone of practice transformation. When we think about practice a number of years ago and a provider sitting in his or her office, he or she would just look at the patient's schedule, see who had called and scheduled an appointment to come in to see them that day. The patient would come in, the needs would be met, patient would go home, and we'd wait for that patient. We might suggest a time frame for them to come back, but if they canceled, we may not have known that they canceled or known that they didn't ever come back until we next saw them or we had some other reason to bring them back to our attention. I think it's probably pretty clear to many of you in the audience that those days are quickly fading away. So data sharing, again, is a critical piece of our relationships with providers that are in value-based models. Data sharing can create a holistic view of the member, or the population, which can include clinical, financial, and operational data. At Capital Blue Cross, we use the FEON platform, which is an analytical tool that has been recently developed by Genea, which is a subsidiary of Capital Blue Cross. Through the use of this platform, we enable our providers, their administrative and clinical staff. We have our clinical team at Capital Blue Cross, all looking at the same data, perhaps from a different angle, as our clinical team would obviously want to focus on the clinical data, and the more administrative individuals would obviously be more interested in financial and perhaps utilization information. But we're still all focused on the same population, and through this platform, which is a web-based platform available with a unique user sign-on that dictates your level of access to different information within the tool, we can easily look at the population as a whole or subsegment that at a practice level or a provider level in order to do some comparative activities where then the organization and working collaboratively with Capital, can better understand and thereby share best practices. So when we started some of these relationships, as Dr. Chambers referenced back in 2011 and 2012, those early meetings when we were meeting with our provider partners, we would take, admittedly, volumes of paper reports that might be somewhat dated till we had appropriate claims run out. And, we certainly received feedback around the timeliness of data and the actionability of that data. I definitely, as a user of the Theon platform on a regular basis, can say we now absolutely deliver data in a much more timely and in a much more actionable format that, again, is supporting our practices and our providers in these value-based relationships, making the best decisions and the most timely decisions to most effectively and efficiently manage their patient population. And now I'm going to pass the baton back to Dr. Chambers, and she is going to summarize some of the outcomes and results that we have seen with our accountable care arrangements over the last several years.
Thanks, Dr. Harr. So let's talk a little bit about the outcomes that we have realized since the inception of our value-based programs. Capital Blue Cross's accountable care arrangements have successfully improved the quality of care for members by fostering collaboration and identifying and driving and understanding the mutual interdependence between providers, hospitals, and allied healthcare providers to align and drive the coordination of care across the continuum. Our accountable care arrangements are meeting or exceeding agreed upon quality goals related to chronic disease management, helping patients who have chronic conditions such as diabetes, coronary artery disease, and congestive heart failure to experience improved health. As Dr. Harr mentioned, we have developed and implemented a quality program that aligns with those measures that providers are working on for other programs with other payers that they may be working with. We believe that alignment of the quality metrics is key to driving improvement in the healthcare outcomes that we are seeking to achieve. Should we have metrics that would not align with those other programs, we would be diluting the efforts of our providers, frustrating them, and not really setting them up for success in our work together. Capital Blue Cross's accountable care arrangements are exceeding the regional average for HEDIS measures for some of the leading chronic diseases. And two that I will call out here is performance of greater than the 95th percentile for comprehensive diabetes care measure for several of our ACA partners, and performance greater than the 90th percentile for cholesterol management for cardiovascular conditions measure. And across all of our accountable care arrangements, we are seeing improved quality outcomes as measured by our performance dashboard. Although not every partner has achieved the target, we are seeing statistically significant improvement in the majority of our measures, and we are proud of that. We are proud of our provider partners for really digging in and working to improve that. Next slide, please. In terms of patient satisfaction, or what we call experience of care, our longest standing accountable care arrangement achieved greater than the 95th percentile in the CG CAPS assessment measures. First, the composite for getting timely appointments, care, and information. For the composite on how well doctors communicate with patients. And third, for doctor's office followed up to give test results. Each of these are very key metrics in driving that higher experience of care that our members are experiencing through these arrangements. And we are getting consistent reports of that satisfaction in the patient and caregiver experience for those members. In addition, we do measure provider satisfaction with their encounters with Capital Blue Cross's clinical teams, and in terms of the arrangement itself, and we are getting consistent, very positive scores in that provider experience arena as well. In terms of other outcomes metrics, I can tell you that all-in risk-adjusted per member per month medical and pharmacy expenses maintain a rate lower than peers and Capital Blue Cross's overall book of business. And the key factor that is driving this limitation in growth rate is improvement in appropriate resource utilization. So you can see to the right, and this is data from a recent 12-month period showing that Capital Blue Cross's ACAs are outperforming their peers for the following measures. First, for the acute care admissions. For our commercial group customers, we are seeing a 4.7% lower rate of acute admissions compared to their peers. And for our Medicare plan customers, a 7.2% lower rate for acute admissions. In terms of readmissions, our commercial group customers are seeing an 8% lower rate. Our Medicare plan customers seeing an almost 15% lower rate of readmissions. We see readmission rates as a marker for lack of good coordinated care at time of discharge. And so as we drive down these rates, we're recognizing really where there was opportunity to improve that discharge planning and coordination process. And by providing the data that Dr. Harr described coming out of our Theon module, we're able to really provide that information about impending discharges and needs that members may have to achieve that better coordination of care at time of discharge. In terms of emergency department visits, our commercial group customers are seeing an 8.4% lower rate than their peers, and our Medicare plan customers are seeing an 8.2% lower rate than their peers. It is really these three key metrics at this time that are driving that lower per member per month rate, and we are definitely seeing the fruits of the labor with driving down these metrics. With that, I will call our webinar to an end, and we believe that this is a great time for questions and for conversation. So we are anxious to hear your feedback and questions, and thank you very much for your kind attention.
And I will say we've had one question, a couple of questions come in so far. But the first question that has been raised is, have you experienced denominator issues with the smaller ACAs? And I can address that question. As Dr. Chambers spoke about our three different ACA models, and specifically around the mini ACA model, what we have done with those relationships, and as Dr. Chambers indicated, these are with small community practices that by themselves are not able to really take on a value-based relationship. When we're looking at the performance of the mini ACA model, we look at the data for those, we look at that data as Capital Blue Cross in aggregate. And so we are scoring or rewarding performance in that model at an aggregate level. However, each of those individual practices has accessible to them their specific data. And again, these are primary care physicians, which would encompass family practice, internal medicine, and/or pediatrics. So there could be, particularly in our quality program, metrics that may not be applicable to a given population. Say, for example, you're a family practice office and you don't see pediatrics, or as an internist, you very likely would not see pediatrics. And as a pediatrician, you may not see adults, or more likely than not, don't see adults. So we realize that there needs to be customization, and there are definitely some issues with small cell size with some of our smaller practices. And again, with our mini ACA model, we have worked around that issue through looking at some of our data in a more aggregate fashion. when we've had issue, and again, I'll speak to our quality program, when we've had issue with our quality program where we may have small denominator sizes on a given metric, this is where, again, that collaboration with our partners is really critical as we might look to think about replacing a given measure with another measure that may be more applicable to a given population, certain measures that may be more applicable to the Medicare population or commercial population, based on the makeup of that provider organization. Again, we work together to keep around the same number of measures, but may swap one in and out, again, depending on what the focus of that organization may be. So I'm hopeful that answers your question. I don't know if there's anything, Dr. Chambers, that you wanted to add to that particular question.
Well, I'll just add a little bit, and that is that, yes, the cell size issue does become an issue. We have chosen to address that as described by Dr. Harr. But in terms of the other aspects of our accountable care program, we still share with those practices best practices. We share ways that they can optimize efficiencies and processes. They have access to our clinical programs to support the work that they're doing. We are also supportive as they re-engineer care delivery and provide resources and education around patient-centered medical home and the opportunities for improvement in those practices. And we have learned a lot over the past 4 or 5 years in this area. So we believe we have a lot of good information to share. And generally, these are going to be our smaller practices, more rural in nature, who really appreciate and benefit from the sharing of that information.
Okay. So our next question is requesting for some additional information to some specifics on how our ACAs are exceeding in the diabetes composite measure. And there was a question around, could we describe maybe a typical care plan or approach to how we might manage a patient that has a chronic condition such as diabetes? And again, I can start with, an answer to that, and certainly, would look to Dr. Chambers to add anything additional as she would see fit. Again, I would speak to the evolution of our accountable care relationship, and admittedly, with many of our partners that we worked with early in 2011 and 2012, as partners were just entering into this space, much of our work focused on just being able to identify those patients who had diabetes. Because again, as I referenced earlier, often in pre-value-based healthcare, we would be in our practices and wait for our diabetics to call us. So one of the first things that we did was provide our partners with a list of everyone that had diabetes. Everyone, and this would come from our claims data as a payer, but everyone that had diabetes or coronary artery disease and or congestive heart failure, or those were the 3 conditions that we started our focus on, but certainly could be applicable to many other chronic diseases. And just making the provider partner aware of who in their population had been diagnosed with these conditions. And then we looked to, with the development and the design of certain metrics that were applicable to that disease state, ensuring that those individual patients were actually getting the tests that they needed. So as we've moved on, and I think Dr. Chambers mentioned earlier, our process measures. So first we need to identify the population. Now we have to get them to get their test. So now we can see what is the outcome of that test so that we can now potentially influence that outcome, influence the control of their blood pressure, the control of their A1C, and then look to making sure that they're getting their preventative services to reduce that acute care utilization that Dr. Chambers spoke to. So again, as we've evolved in this model, our approach from more process-oriented activities that the clinical team would have been incorporating into their care plan or the approach has now evolved into one that is more about effectively managing that disease, meeting the patient where they are, utilizing intrinsic coaching and motivational interviewing, and developing that care plan and setting the goals with the patient to figure out what is the best way to, and in what order to kind of approach the different challenges that are facing them.
And I would just like to add that as we talk about accountable care and really what is that kind of holistic view of that patient, we at a health plan have access to claims information, and in a previous lifetime, I will say now that we have Theon, I would say that what we did was we attempted to identify members who would benefit from disease or case management primarily through that data. So a couple things. First, Theon brings a new capability around clinical data coming from our provider practices, and that's integrated then with claims data that provides a more holistic 360-degree view of that member, and with the provider practice at our side identifying who are going to be the right folks to outreach to. For those practices that can benefit from our clinical support, we call on behalf of the practice and identify ourselves as calling on behalf of Dr. So-and-so, and we have seen that we have had some very, very good engagement rates, and that is in part due to the motivational interviewing and the experienced and dedicated staff that we have here at Capitol, but also the fact that we're identifying them through a real need that has been detected. So it really provides for an enhanced view of who needs the services, and because they're in greater need, they tend to engage better and at a higher rate is what I mean. So, so the process of identifying and then the process of engaging, and then the last piece is who has those gaps in care. Again, that module in Theon that helps us to know where is that gap in care. Is it in getting a blood test? Can we make an outreach call to get that person in for the blood test? And making sure that they're even seeing their provider. We're able to identify folks that haven't been into their practice for a period of time that really need to be seen, getting those gaps closed with lab tests and other services. So we believe that that the programmatic approach that we have taken with accountable care has really provided that wraparound vision of who could best benefit, and then driving to achieve that outcome using the analytics tools and clinical support staff that we have here.
And I would just pick up on Dr. Chambers' discussion around Theon, because we've had a couple of other questions that have come in around that tool and the different individuals that may have access to or see the data in that tool. What we've presented and have been discussing today is the platform in general, but there are modules as we speak about them that are appropriate for different audiences. And at this time, while we have a module that is most applicable to the administrators of a practice or organization, and that could include, again, non-clinical staff, but also clinical team members or lead physicians, medical directors, who, again, may be responsible for looking at the population from an overview perspective, but then being able to sub-segment that population and potentially do some practice and or provider comparison. We then have another module that is most specific and applicable to the clinical team. And this would really primarily be your non-physician clinical staff. Not that it's not appropriate for the physician, but it's really the clinical staff that will be working directly with the patients around needed care and services, coordinating care amongst various treating providers, potentially doing some outreach around acute care utilization. How can we impact readmissions, understanding why they might have gone to the emergency department instead of calling their primary care doctor. So this would be a module that is, again, directly used by that clinical team. I know there was a question if the patient themselves had access to this information, and admittedly, they're not necessarily the intended audience for this particular tool, but yet their information and their input as to the information that is included in this tool is very essential. One of the nice features around this clinical module is the ability to house the neighborhood. And what I mean by that is all of the treating providers that are involved with that patient's care. There would be a screen where you can see the primary care doctor, the cardiologist, the pulmonologist, the gastroenterologist, maybe the hospitalist, whoever else, the chiropractor, the eye doctor. We can have at ready reference any other treating provider, including contact information. But in addition to that, there would be information that the patient themselves would say, here is my medical power of attorney. Here is my spouse or my daughter or son who I want to be that ready access. If you can't reach me, here it is. And one of the nice features about this tool, and as it continues to be enhanced, is it has the capability to have integration with the electronic health records of our providers, in addition to receiving data feeds from labs or pharmacy. So the more integration of that data that is pulled into this tool, the more we know about the member and therefore can help to guide them to the appropriate care. So I'm hopeful that that has answered many of the questions that have come in around that, the FEON tool. Looking here for some additional questions. We had some around the quality program and how we set those target benchmarks for some of our HEDIS measures. And again, I'll maybe start the answer, and Dr. Chambers can add some additional information. Certainly, when we look at not only the measures that are in the program, but then how we set those targets or those benchmarks, there's a lot of analysis that goes into that. Certainly, we would like to have our providers at least be meeting the 50th percentile, which means that they're doing at least as good as half of their peers. But truly, we want to be able to look at the individual organization and meet the provider organization where they are. We have some very sophisticated health systems that setting higher targets may be much more appropriate. And certainly in the course of conversations, when we're having these early discussions, that's the very first question that we get asked. Well, where are we performing now? So as to how easy is it for us to achieve that targeted benchmark. So I will say that that is an area where we have a lot of collaboration and discussion, but just, I'm sure, like the organization themselves, we want to be in a process of continual improvement. So I will freely say that this program is not just a freebie or a giveaway, that we're setting real targets and high expectations, but not unattainable expectations for performance.
Agreed. And I will also just reiterate the fact that we are looking to see improvement in performance as well as ultimate achievement of the target that has been set. And we do reward for both, but at different levels. And so we look at the Mid-Atlantic Quality Compass as an area where we could determine where the provider is performing compared to their peers in this region, and the region that Capital Blue Cross exists within. So we believe that it is a good benchmark for us to be comparing to. And in terms of driving that improvement, we have, as I mentioned earlier, seen consistent improvement in the quality metrics when we when we give that area of focus and we give the providers an area of consistent focus, not just with our metrics, but with the metrics that they're seeing with other partners, that does not dilute their efforts. It really enhances that everyone is rowing together in that same direction. So as Dr. Harr mentioned, it is a collaborative effort as we sit down together, identify where the provider is, meet them where they are, and determine what the right goal is. We do generally set a standard of 1 standard deviation improvement as a minimum to demonstrate that they have meaningfully improved in that metric, which is it's a one-sided t-test, and it is also a standard that is used by NCQA in their HEDIS effect size table. So we have been consistent in the application of that expectation and believe that it is an appropriate and transparent, nationally recognized approach. Next question.
I think we have time for maybe one more question, and there was a couple that had come in around patient-centered medical home. And I think both Dr. Chambers and I, referenced patient-centered medical home throughout the course of our presentation this afternoon, and just wanted to maybe clarify a couple of points which I think will help to answer some of the questions that were raised. Certainly, as we've described this afternoon, our value-based program really centers around accountable care arrangements. We have not been prescriptive in requiring patient-centered medical home certification. That being said, to be successful in accountable care, implementing and really living the principles of patient-centered medical home are really going to be what drives success in an accountable care arrangement. So I spoke earlier when we were talking about the clinical component and the clinical support piece of our accountable care model and how we do a needs assessment to really understand what services or support the practice or the organization may already be performing. We do a similar assessment early in conversations with potential partners around whether or not they are working towards or have already achieved patient-centered medical home certification, and if not, where they are in that continuum. And we have definitely provided some education and some support in that arena. And really, if we have practices that have not really entered that space yet, are really looking, and I would reference this to kind of many of the practices that we brought into the mini ACA model, where we are providing a much higher touch support, education, and guidance to those practices to assist them in their progress towards that patient-centered medical home care delivery model. I don't know, Dr. Chambers, anything to add to that?
Yeah, I think that was really a comprehensive answer. I believe that, our intent is to say that if you walk the walk with patient-centered medical home principles and concepts, irregardless of recognition or not through NCQA or others, it's really the outcomes that everyone is looking for that really dictates success or failure in an accountable care arrangement. And so whether that practice chooses to go through a recognition exercise or not, it will be incumbent on the practice to really incorporate that practice transformation to be very patient-centered and to really follow the principles around the patient-centered medical home model to drive the improvements and successes that are required to be successful in an accountable care arrangement. So that was, I think, the intent of both of our comments around patient-centered medical home.
I think that's probably the time that we have. I appreciate certainly everyone's questions and interest in the accountable care arrangements that we have implemented here at Capital Blue Cross. And I think what I'm going to do now is turn things back over to Randy, who's going to do a little bit of wrap up here to end our session today.
Thank you. We would like to take this opportunity to thank our speakers and session participants for joining us today. We will be sending a follow-up feedback form at the conclusion of this event and would love to receive any feedback you wish to share. If you haven't already done so, please be sure to join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.